haciendo, le vamos a dar continuación a nuestro curso de inglés, que es Brain Beyond Barriers. Vamos a dar el tema voy a dar el tema de Neurological Examination, o Neurological Exam. Y esto, ok, ¿ven mi cámara? Creo que sí se ve. Perfecto. Esto lo voy a dar en dos partes. Vamos a abarcar dos partes del Neurological Exam. Y después de esto vamos a tener un taller presencial de Neurological Examination. ¿Ok? Para que todo este conocimiento quede consolidado. Entonces sí requiero que presten atención a la hora de hacer el taller en modalidad presencial. Ustedes puedan aplicar todos estos conocimientos que vamos a estar aprendiendo en estas clases en línea. Voy a compartir mi pantalla. Y por favor me podrían confirmar si se ve. ¿Sí se ve? ¿Me escucho bien? ¿Todo se ve bien?
Sí, sí se ve.
Ok, perfecto. Perfecto. Mientras me escuche bien, todo se ve bien. Si, por favor, si tengo problemas con mi internet o con el video o con cualquier parte, me podrían mandar mensaje. Por WhatsApp los veo mucho mejor. Ok. Okay. So today's topic is neurological exam. And to begin with our topic properly, objectives of neurological examination. The main purpose of a neurological examination is to assess the function of central and peripheral nervous systems and to then identify signs and symptoms of neurological disorders. That's in somehow like a general perspective. But there's an order. So we have to follow this order because this is like the main order we have in a neurologic exam. First, we're going to view our mental status, the mental status of our patient. Then we're going to explore all cranial nerves. After that, motor and sensory function. Um, then we go with our reflexes, coordination, and gait. If you don't understand any of these subtitles, maybe we could go ahead and we'll explain them further. So remember that before our neurologic exam, we're going to have initial steps in patient history. And we already saw this topic our last lesson is patient history. It is important that we already have our detailed history taken, for example, past illnesses, medications, family history, all of these things we already saw in our previous lesson, and to make a proper general examination before the neurologic exam. It's the general examination, and we're going to assess our patient's general appearance. And most of neurological disorders are like pretty, you can easily look into them in a clinical feature. So it is important that you examine your patient in the very exact moment they come into the door. For example, how they walk, how is their gait, how is their appearance, how is the posture, if they have if they are not coordinated, or if they have any involuntary movements. So this is going to be very important before we properly begin our neurologic exam. So first, we're going to look into the mental status. So there are two key components in our mental status exam. First, we're going to be level of consciousness. But we're going to make two key questions regarding the mental status exam. The first question is the patient's level of consciousness normal or impaired? Okay? Level of unconsciousness is like normal or impaired. It can be normal or impaired. How are we going to review this? It's like if we have a patient and the patient comes and he's alert and responsive, like it's kind of the same in Spanish. So I hope it's like understandable. It's like it's alert responsive, or if the patient is stuporous or if it's in coma. So in the level of consciousness is normal or impaired. And the other key question is, are there any cognitive function abnormalities? So the first one is level of consciousness, and the second one is cognitive function. Okay, so first, level of unconsciousness is normal or impaired or abnormal responses to visual and verbal cues. What is a cue? Like visual and verbal, like I'm like an examiner. I'm going to make the cue, and the patient, and I'm going to examine the patient's response to my cue. So so when the patient is alert and it's responsive, is that he's awake. He's awake and he's talking and he answers our questions, and he's just like responsive. So we are going to locate him in this side, like if the response is coherent, like the language is like a proper language. You can understand the patient. He's fluent in his language. He's coherent. He understands your verbal cues, your visual cues. So that's like a normal consciousness, like a normal level of consciousness. All right. So then the verbal or visual, at the verbal or visual cue, if the patient is coherent, it's normal. So then maybe it's not really coherent, but it's purposeful. Like he tries to do it. It's somehow difficult for the patient to do it, but he tries to. And you can see like this intention of making like some response, like okay, he's trying, maybe he's in pain and maybe he doesn't do it really well, but he's trying, so he's purposeful. Now, maybe the patient doesn't respond like to a verbal or visual cue, but maybe to a tactile cue, like tactile. You're going to touch the patient. It's like, hey, are you okay? Hey, how are you? Hey, I'm here. What's going on? And maybe the patient is moving in at this stage, right? So it's like semi-purposeful. But here, the level of consciousness is not normal. It's not normal consciousness. So it's like a depressed consciousness. So it's like a tactile stimulus. At a tactile stimulus, the patient is like semi-purposeful. So that's like a depressed consciousness. Then we're going to have this, like at a painful reflex, like a painful stimulus, the patient maybe could be reflexive. Maybe if you like do like a painful stimulus, for example, here in the thorax, like hey, or maybe just like press like the patient, but it has to be like the painful stimulus, and the patient must be like sometimes it's like reflexive. Maybe the patient moves, he cannot talk, he cannot like make any alert or responsive um, answer, but maybe he can make some gesture in the face, like a painful gesture, or he moves a little, that's reflexive, or maybe he doesn't have any response at all. It's like non response. So the patient would be here, like in a coma. So that's the level of consciousness. Is responsive, is already responsive, but the patient is like reflexive or none. Or but maybe there's not any stimulus at all, and the patient is reflective or none. So he is like directly into a coma. Two components. The second component of the mental status exam is the cognitive function. The cognitive function, uh, here we are going to assess memory, language, after thinking, and mood. The first one is attention. Attention, it is described like an ability to focus on a particular sensory stimulus. Like he has the patient has his attention to something in particular. Concentration is like a sustained attention. And we're going to also examine orientation. Orientation is like the patient has to feel orientated, like in space and time, like where he is at, maybe what time is he at, and at that precise moment. And also we're going to examine memory. Por favor, podrían apagar sus micrófonos. Okay, gracias. Okay, memory. First things first, immediate recall. We're going to examine immediate recall. Immediate recall is the very first memory we have. Like, I'm going to tell you something now. For example, I'm going to tell you a word, apple, and you immediately recall that word. Like, okay, what word did I say? Oh, you said apple. Okay, that's immediate recall. Recent memory. Maybe we're going to examine the memory like in 5 minutes, 10 minutes. So that's going to be recent memory. Remote memory. Maybe we're going to ask our patient, what did you eat like last week on Monday? What was your first meal on Monday? And we are already on Saturday, perhaps. And so that's going to be like a remote memory. Or do you remember what's the name of your first pet or something like that? And some disorders, in some memory disorders, we could have amnesia or psychogenic amnesia. So we're going to be examining this area to like to probably find some disorders. Also, like if we have like an elderly patient, maybe we could have like some Alzheimer or something like that. And number three, language. And in language, you're going to turn fluency, comprehension, repetition, naming, reading, and writing. So the patient has to be uh, fully able to do all of these type of languages. If we have like a disorder or an impairment in our language, the patient is going to have something called aphasia. And we have many different types of aphasias if you would like to view them later. Also, we're going to have like higher intellectual function. It's like general knowledge of the patient, just to evaluate this cognitive function properly. Like general knowledge, abstraction, judgment, insight, reasoning. And then we're going to examine mood and effect. Like the patient, how do you feel? Do you feel happy? Do you feel like angry or depressed? Or have you ever had any anxious feeling lately? So this also is part of cognitive function. And to probably examine like a proper cognitive function, we have this technique. Okay, so we have like two tests we could use in this part. Like the first one is like a mini mental status screen exam. You probably have seen this already. Or like the MOCA. The MOCA, it's also to examine cognitive function. So here are all of these characteristics we already saw. It's like orientation, time, place, immediate recall, attention, delayed recall, language, visual impairment. And the score assessment, uh, we could determine that the patient is normal, like it's like it has like a proper cognitive function if we have from up to like 30 to 27 points. It's like going to be like our normal score. But if the patient has like probably 26 from 20, it's like a probable mild dementia, like from 19 to 10 probable moderate dementia, and from 9 to 0 it's like probable advanced dementia. And also we have mocha. It's almost the same. It's, as you can see, like it also examines the same things like visual spatial executive, naming, memory, attention, language abstraction, delivery, call, orientation. And so you could use like either this one or either that one, but both are from for cognitive function. So that's all of mental status. So we're moving to cranial nerves. So this is really, really important also in like in a neurologic exam. And we're going to begin with cranial nerve number one, which is going to be like olfactory nerve. Olfactory nerve, it's really simple, like really easy to evaluate. Why? Because it's just like, do you breathe correctly? Like, can you breathe? But we have to be sure that the patient doesn't have like rhinitis, polyps, or something that could be probably obstructing our nasal passage. Because if that's the case, we're not going to like examine this nerve properly, because it's not going to be like a nerve lesion or something like that. Maybe it's just something that the patient has that is going to be obstructing our nasal passage, and we could make like differential diagnosis or maybe make a false positive diagnosis over there if the patient has those kind of pathologies, right? So we're going to ask our patient to have his eyes closed. Then we're going to clip one nostril, maybe ask the patient to clip one nostril and test the other one that's open. And we're going to compare those sides. For this particular exam, we're going to use non-irritating substances. Like, please don't use like something that could be really harmful for the patient, or it could be like something. For example, if you use like something spicy or something like that, that could be irritating, like an irritating substance, right? And maybe use like a coffee bean, some chocolate or something like that, something that's also easily detected, and it's like something really common, because sometimes we use like some things that have menthol or something like that, and that's not really, that could be irritating for the patient. So we're going to clip one nostril, and that's this one, like, and then we're going to include the other one, like, hey, can you smell this thing? What is it? Oh, it's like a coffee bean. Okay. So then we alternate to the other nostril, like, what is this? Oh, that's chocolate, maybe. And can you smell like properly in both nostrils? Yeah, I can. Great. He is absolutely great. The second cranial nerve, optic nerve. Here we're going to evaluate four things like visual acuity, visual fields, endoscopy, and afferent limb of pupillary refraction. First, to evaluate visual acuity, we could use like two techniques. First one is like Snellen eye chart. In the Snellen eye chart, it's like for long distance vision, and the patient is located like approximately 6 meters away from this for distant vision. And Rosenbaum pocket eye chart is for like closer vision. Okay, so the patient is like located like approximately 36 centimeters away for near vision. So we could use both of them. We're not going to like examine some refractory probably pathology. We're going to examine if the patient has like some optic nerve lesion. like a nerve lesion properly. So you don't really mind if the patient has glasses on or the patient doesn't, but he has to have glasses on and cover one eye and then cover the other eye. Glasses on if the patient uses glasses, of course. If he doesn't use glasses, of course, you're not going to ask for glasses on. But if the patient does, it's like, please, could you put your glasses on? We're just going to evaluate if you can see properly and in one eye and then the other. So that's visual acuity. Then for visual fields, we're going to use something that's named confrontation technique. So we're going to locate ourselves in front of our patient. Patient is going to be in front of us. And then we're going to ask the patient to cover one eye. Okay. So the patient is covering one eye. And then you're going to locate like one finger. And you're going to move the finger up to this field, like our visual field, like this field. Okay. And you're going to ask the patient, please do tell me when you stop seeing my finger. Okay. When you stop seeing my finger, that's where you're going to tell me. So this visual field, we're going to be examining optic nerve. Maybe the patient has a lesion of some visual field. So it may be the patient, in a normal, you, I mean, I can see my finger from up to here. Over here, I can see my finger because I have this panoramic view. If you can see the angles, we can reach up to this angle, right? Like from up, down, and like in a horizontal view. Okay, so this confrontation technique, it's like this technique where you can see, okay, I can see from here, and I can see from here. But for example, from here, like 60 degrees, like I cannot see 100 degrees, like 60 degrees, but 100 degrees I can. Okay, that's normal, but some visual defects cannot do this properly. Okay, so that's the confrontation technique. After this, we're going to do a fundoscopic exam, also called like ophthalmoscopy, and we're going to use an ophthalmoscope. In the fundoscopic exam, as the name says, we're going to examine our optic fundus. The fundus, like it's represented in this image, we can see like these important parts. So it's like fovea, the macula, the optic disc, an arteriole, and vein. Like if you already know these structures, um, it is important to know every single structure, of course, of the optic fundus. But if you already know these structures and how do they look normally, of course, you can recognize how they do not look normal. So it is important. Why? Because in neurologic patients, the most important abnormality to identify is swelling of the optic disc right here. That's resulting from increased intracranial pressure. And this is called papilledema. So then here is like a normal optic fundus, like fundus. We have like our normal optic disc over here, but let's see the other side. Like in contrast, we have like a papilledema, and here's like a swelling of the optic disc. Like this is not normal. You can see over here that's how different it is, like to have like a papilledema, and that's going to be like due to an increase in intracranial pressure. Then, popular function. Popular function, here we are covering two nerves, the second cranial nerve and cranial number 3. So, normal purpose pupils are equal in size and shape and are situated in the center of the iris. Okay, that's basic knowledge, right? Now, popular size varies from with intensity of ambient light, but at average intensity is from 3 to 4 millimeters. So that's normal. But if we have less than 2 millimeters, this is like something physiological depending on the ambient light, we're going to have meiosis. If we're like it's sitting from like above 5 millimeters, we're going to have mydriasis. If there is like a pupillary asymmetry, it's called anisocoria. So these are like the common pathologies you can find in the patient. For example, meiosis and mydriasis, it's normal depending the ambient light. And how are we going to examine that? The light reflects. The light reflects. For the light reflect examination, we have to have dim lights. Like you cannot have like a bright light. Why? Because bright light is going to, of course, cause you like direct mydriasis, right? You have to have dim lights, and then you have to shine bright light obliquely into each pupil. So you're going to have your flashlight over here, and maybe like do this to one pupil. And at the same time, you have to examine the other pupil. Why? Because you have to see these consensual reflex that both pupils are reacting to the same stimulus. You have the light stimulus, and both pupils are going to be reacting to the same stimulus. So that's like a consensual, that's like a consensual reaction. So you look into the same eye, and you're going to look to that reflex, and then you're going to look to the opposite eye, it's like consensual reflex, to see if they are both like the same. Okay, and that's like in a normal basis, right? But if the patient has something called anisocoria, the pupils are going to be asymmetric. All right, so that's the light reflex, how we're going to examine the light reflex. Then we're going to have our accommodation reflex. We're going to hold the finger 10 centimeters from patient's nose, your finger. And then we're going to alternate looking into distance and at the finger. So we're going to ask the patient, okay, please look at the tip of my finger, the tip of my finger, and then follow it. And we're going to do this, like pull it closer to the nose. And the patient has to follow it, and to follow it with both his eyes. So we're going to observe the pupillary response. And this is going to be like our accommodation reflex. So moving forward to our ocular nerves. These ocular nerves are, all of them are explored at the same time, because all of them are connected in their functions. We have cranial nerve number 3, oculomotor nerve, cranial nerve 4, trochlear nerve, and cranial nerve 6, abducens nerve. That's also like called from extraocular. That's for extraocular movements. So in ocular nerves, we're going to examine pupils, as we already saw. We already saw how to examine pupils, but also we're going to examine eyelids and orbits. Why? Because if the patient has some disorder of this, like for example, trochlear nerve or something like that, maybe he has ptosis. Ptosis, like when the eyelid moves like this, the patient has like this eyelid or like this, right? So that's ptosis. Also, we're going to evaluate like eye movements, uh, tracular movements. Like we're going to ask our patient, please also follow my finger. You're going to move your eyes to this way, like horizontal, up, down. Like you're going to move your finger like to every single direction, because we're going to be examining how, like, if the patient can move his eyes to all directions properly. And here we're going to be examining these tracular movements, and if any oculomotor nerve is like probably impaired. Okay, if it has a lesion in this nerve. Then we're going to examine ocular oscillations, or also called nystagmus. This nystagmus, it's going to be this movement of the eye, but it's like this is like a constant movement of the eye. If you already saw the topic, you can understand. But for example, here we have like a graphic example. And maybe if you don't get this properly, you could probably look further in a video how the nystagmus is seen. But M position nystagmus is in like this, like we have like here a patient, if we have like our eye looking forward, maybe the eye is moving like this. All right, that's kind of an nystagmus. So this is going to be like an nystagmus in primary position. And maybe if we ask the patient, like, can you move your eye to this way? And the patient is going to move the eye to this way. And it's going to continue to like this movement. It's going to keep up this movement. And it's going to move, 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 move. And that's going to be like an nystagmus. All right. So we're going to examine nystagmus also in this part. Cranial nerve number 5 is going to be the trigeminal nerve. The trigeminal nerve, as you already may know, it has like three divisions: the ophthalmic division, maxillary division, and mandibular division. But this is like a nerve that has like a sensitive part and a motor part. So we're going to evaluate both of them. So for like sensitive part, we're just going to maybe use something that the patient can feel, maybe some cotton, something that has like a cotton end, a cotton tip, and maybe just we're going to ask him like to close your eyes. So, okay, and tell me if you feel this stimulus. So the patient is going to close his eyes, and you're going to touch it, like touch it here, touch it here, touch it here, touch it here, and in both sides of the face, like here, here, and here, 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 and over here. And we're going to ask our patient, and please let me know when you feel, okay, so, okay, I feel it. I can feel it. I can feel it. I can feel this. I can feel this. I can feel this. That's like a normal basis. But maybe the patient has like a lesion through trigeminal nerve. Of course, he's not going to feel this stimulus. Okay. So for the motor part, we're going to have like the masseter strength. So we're going to ask our patient, we're going to put our hands here in the mandible of the patient, and we're going to ask him like to open his mouth, and we're going to apply some force that's opposite to the movement of the jaw. Okay, so it's like, can you open your mouth? And he's going to try to open his mouth and put on some resistance to our hands. So can you open your mouth, please? Like with strength, right? And if the patient has a strength, that's normal. When it is normal? When the patient can't even open the mouth. That's not normal. That's saying that we have a lesion in the trigeminal nerve. Also, the jaw jerk. We're going to ask our patient maybe to bite something, but bite it hard, and we're going to move that thing, all right? And the corneal reflex. The corneal reflex also can be like um, examined with like a cotton tip, and we're going to place our cotton tip here. And if the patient automatically closes the eye, it's like that's a corneal reflex. That's normal. That's what it is expected. Okay. Then moving forward to cranial nerve number 7, we have our facial nerve. The facial nerve supplies the facial muscles and mediates the sensation run about the anterior 2/3 of the tongue. So this is going to be like a facial nerve, and here in the back, it's going to be our cranial nerve, our 11th cranial nerve. Okay, so we're going to evaluate this part the examiner is going to look for symmetry or asymmetry in facial nerve. Why? Because facial nerve, something, a normal pathology of facial nerve is going to be facial palsy. Facial palsy, it could be, remember, central, peripheral facial palsy. So we are going to look for this symmetry or asymmetry, asking our patient first to wrinkle the forehead. Hey, sir. Hey, ma'am. Can you wrinkle your forehead? Forehead. So this is like wrinkling the forehead. Okay. Oh, can you squeeze the eyes tightly shut? That's squeezing the eyes tightly shut. Can you smile like big? Show the teeth big, like a wide smile, wide. Um, or like open your mouth widely. Okay. Squeeze both eyes tightly shut. That's sorry, that's repeated. And also press the lips tightly together, tightly, and puff out the cheeks like this. That's like puff out the cheeks. So that's the orders we're going to give our patient, like wrinkle the forehead, squeeze the eyes slightly shut. And if there's an asymmetry, maybe we could have over there like a facial palsy. Okay. Now, cranial nerve 8. This is called auditory or vestibulocochlear nerve. Here, we're going to examine two things: hearing and also equilibrium. Hearing and equilibrium. Hearing is properly from cochlear nerve, and equilibrium is from the vestibular part. So for hearing, we're going to test with the finger rubbing. This is like the finger rubbing. If you do this with your hands, that's a finger rubbing. And if you have like a proper auditory function, you're going to be able to hear this. Like if you rub your fingers approximately like 5 centimeters from your ear, you're going to be able to hear this. Like listen to this, do it yourself. If you can hear it, like a faint rubbing, that's normal. But if you can't hear strong rubbing, that's an impaired hearing. So then we're going to have like an otoscopic inspection of the auditory canals and tympanic membranes, assessment of auditory acuity in each ear. Also, that's really important. And we can also use like the Weber and Rinet test. And these are performed with a 512 hertz tuning fork. And this fork, um, okay, let me do like a quick close up over here. Like this is the Weber test, this is the Rinet test. So this fork, like for the Weber test, the fork is like placed over of the in the base of the stroke tuning fork on bridge of the forehead, nose or teeth. So it is normal when you first you're going to like stick the like probably hit the fork because it has to vibrate like to this make this vibration, because if you don't do anything, it's not to do that vibration, and we have to have like that vibration. And then we're going to place it over here, and normal, there's no lateralization. The patient doesn't feel like this vibration like going to one ear and not the other one. But when it is abnormal, when it is like unilateral conductive loss. So in a conductive loss, if the loss is conductive, the lateralization is going to go to the affected side. Affected side is like going to be like the sick ear. Okay, so that's going to be like conductive loss if it goes like to the affected side. Now, if there is like a sensory neural loss, the lateralization of the vibration, it's going to be go to normal or better hearing side. But and then if the lateralization goes to this normal side, the other one is going to be the affected side. So there's like a difference in one conductive loss or a sensory neural loss. For Rinet test, We're going to do the same. We're going to move the fork, and then we're going to hold it at base beside ear and ask if is it now audible? Like, can you hear this? Can you hear this vibration? So that's going to be like the air conduction. And then we're going to have bone conduction. Conduction is going to be placed vasostructuring fork on the mastoid point. Sorry, I'm confused. Like, this is the bone conduction. And we're going to have a patient indicate when the sound is no longer heard. Okay? Air conduction, held at base, beside ear, and as if it's audible. Bone conduction is going to be placed on the structure fork on the mastoid bone. That's bone conduction, okay? Normal. It is normal when air conduction, it's more audible than bone conduction. So the patient can hear fork at ear. When there's a conductive loss, when bone conduction, you can hear it better than air conduction. Okay, so the patient will not hear fork at ear. So that's the Weber test and that's the Rinet test. Okay, sensory neural means that it's involving inner ear, cochlea, or the auditory nerve. If it is conductive, it means it is involving any cause that limits the amount of external sound from gaining access to the inner ear. For example, it could be cerumen impaction, and the patient is going to have like a conductive affection. Now, it could also be mixed when it's like a combination of conductive and sensory neural hearing loss. So that's why we use Weber test and Rinus test in this examination. Now, maybe a patient is complaining about having vertigo or having also like nystagmus. So we're going to use two techniques. The one is the nylon barony or the Ditz Hole Pike maneuver. These maneuvers can be used to try to reproduce the symptom. We're going to try to reproduce the vertigo in our patient. So how is this technique performed? The patient is going to be seated on a table with the head and eyes directed forward and is then quickly lowered. It's like, so the patient's over here and then it's quickly lowered to supine position with the head over the table edge and 30 degrees below horizontal. Test is repeated with the patient's head and eyes turned 45 degrees to the right and again with the head and eyes turned 45 degrees to the left. The eyes are observed for nystagmus. Remember the nystagmus? And the patient is asked to note the onset, severity, and cessation of vertigo if it occurs. Okay, here's like a visual representation of this technique. Now, moving to cranial nerve 9, glossopharyngeal, and cranial nerve 10, vagus nerve, are both explored at the same time. Testing centers on motor function. We're going to look into palate elevation. We're going to ask our patient to open his mouth wide, like open your mouth wide, and please reproduce this sound ah, like please make ah. So we're going to evaluate over here, like the palate elevation. Also, can you swallow? The voice, cough, and the gag reflex. The gag reflex is like this when the patient wants to like vomit, like that's the gag reflex. Okay, so maybe we can insert like a cotton tip and provoke that gag reflex. It is normal that the patient has the gag reflex, like okay, I can I have this sensation, like this nauseous sensation that I want to throw up. Okay, so that's normal. Palate elevation, swallowing, voice, cough, and gag reflex. That's testing centers of motor function of cranial nerve 9 and 10. Then, cranial nerve 11, spinal accessory nerve. For spinal accessory nerve, we're going to locate ourselves in front of our patient, and we're going to evaluate trapezius and sternocleidomastoid. First, we're going to put our hands in the shoulders of our patient, and we're going to ask our patient to shrug shoulders or and push head back, okay? And we're going to put on some resistance in our patient, like we're please can you like shrug your shoulders, and you can please like put the head back, and this we're going to put this resistance to see if the patient has some strength in these muscles. So that's what is it is expected. The patient has some tone. Like if he has some tone and he has some strength, that's like normal. But if there isn't any resistance, of course that's abnormal, and it could be telling us that the patient has some nerve lesion. Sternocleidomastoid, we're going to place a hand on our face and have patient rotate the head toward that side. And we're going to observe the opposite contraction of the sternocleidomastoid. So this resistance, like, like, can you like rotate the head toward this side? Okay. Then to this side. Okay, you're going to examine the contraction of the opposite, the sternocleidomastoid. And then to finish this part of cranial nerves, the last cranial nerve, number 12, it's hypoglossal nerve. And first we're going to use like this thumb position at rest and on protrusion. I mean, like, can you show me your tongue? And if tongue deviates in either position, that could be talking about like a lesion or hypoglossal nerve. And you can also examine the node strength and rapidity of movements, and have the patient push tongue into each cheek like this, like just move your tongue, like move your tongue to this side, to this side. That's normal. Okay, great. So this is going to be everything. Esto va a ser todo ya por el día de hoy. Ya para la siguiente clase continuamos con la segunda parte. No sé si alguien tenga alguna duda de una parte, gusta que les repita alguna técnica, gusta que repita la exploración de un nervio craneal, comentarios, sugerencias, algo. Si quieres ya podemos detener la grabación en lo que hay preguntas. No sé si ya se envió link de asistencia. Si no, este es un buen momento para mandar link de asistencia. Lu, ¿estás por ahí? Creo que no está en la reunión. Ok, ninguna duda. Todo quedó claro. Acuérdense que vamos a tener el taller presencial. Entonces es importante que sí repasen sobre todo los términos en inglés. Aunque ya sepan hacer la evaluación, la examinación en español, es importante que lo hagamos en inglés, porque vamos a tratar, lo que vamos a hacer en el taller presencial es que ustedes pues van a interpretar como una evaluación clínica, obviamente neurológica, y le van a hacer las preguntas al paciente. O sea, se lo van a decir en inglés, le van a dar las órdenes en inglés, o sea, como lo que ya vimos, o sea, podría ser esto, podría ser el otro, pero lo van a hacer en inglés. Entonces repasen bien, chicos, repasen bien esta parte, y yo creo que en noviembre, como mediados, finales de noviembre, estamos haciendo el taller, ¿vale? Y es importante su asistencia. Ay, creo que no tenemos ni asistencia el día de hoy. Pero bueno, ahí vemos cómo tomamos la asistencia. ¿Podemos descargar una lista ya él de Zoom?
Sí, Jimé, yo creo que sí, a ver, déjame reviso.
Ok, igual ya podemos terminar la grabación. No se salgan todavía, pero si nada, hasta que ya él nos avise que ya descargó la lista, y ya, así les damos asistencia.
Ya quedó.
Perfecto, muchísimas gracias. Muchas gracias, chicos. por su atención y que tengan una linda noche y un